Welcome back to Jalen Bio. Today's module is on ventilation, pressure differentials and gradients. The atmosphere is the air in the environment that surrounds us. Atmospheric pressure is a pressure that gases in the air exert in the environment. The accepted pressure is that the pressure at the sea level is roughly about 760 millimeters of mercury. The collective volume of the alveoli within the lungs is called the alveolar volume, and it's associated with the pressure known as the intrapulmonary pressure. Intrapulmonary pressure fluctuates with breathing and equals about 760 millimeters of mercury at the end of both inspiration and expiration. The pressure within the pleural cavity, which is the layer between the visceral and the parietal pleura, is also known as the intrapleural pressure. It's generally about 4 millimeters of mercury lower than intrapulmonary pressure. So on the left-hand side, we have the pressure gradient between the atmosphere and the alveoli. Atmospheric pressure is 760. The alveolar pressure is 758. So the difference is 2. The pressure gradient between the alveolar and the pleural spaces is 760 millimeters of mercury in the alveolar pressure, and the pleural pressure is 754, so the difference is about 6 millimeters of mercury. There's no pathway between the alveoli and the pleural space, therefore there's really no gradient. The pressure flow will go from the atmosphere into the alveoli and vice versa. So the relationship of volume and pressure is described by Boyle's law. Boyle's law states that at a constant temperature, the pressure of a gas decreases if the volume of the container increases. The law is represented by P1 V1 is equal to P2 V2. As the air pressure gradient occurs, the force per unit area is greater in one place than the other. Air will then move from the area that has a higher pressure to the area with a lower pressure. Some factors that can determine this is the amount of gas particles inside a chamber, the temperature. If the temperature increases while all other factors remain the same, pressure increases, and then the volume of space. If the volume increases while all other factors stay the same, the pressure will have to decrease. Airflow. Airflow is the amount of air that moves into and out of lungs with each breath. F stands for flow rate, which is directly related to the pressure gradient between the atmosphere and the lungs, expressed as delta P, also known as pressure differential. And it's inversely related to uppercase R, which is the resistance against the flow. Therefore, the formula is also known as F is equal to delta P over R. What is this pressure gradient, pressure differential? The pressure gradient is the difference between the atmospheric pressure and the intrapulmonary pressure, which is the driving force for airflow into and out of the lungs. Our skeletal muscles help establish this pressure difference. What causes resistance? Resistance includes all the factors that make it difficult for air to move from the atmosphere into the alveoli. It is if there is a decrease in elasticity. When there's a decrease in elasticity, the chest wall in the lungs, there's going to be a change in the bronchial diameter and a change in compliance. Whenever the airways increase in bronchoconstriction, this will then cause the airways to get smaller. Resistance is also affected by compliance, which is the ease by which the chest wall and the lungs can expand and be able to be distendable. The more stretchy the chest wall is, the greater the compliance. Therefore, the elasticity of the chest wall and the lungs is decreased whenever there's a malformation of the vertebral column. For example, if you have arthritis or any kind of scar tissue. Compliance is influenced by the surface tension of the alveoli, which is directly related to the surfactant. Increasing in surface tension occurs if the type 2 cells are not producing enough surfactant. Some respiratory diseases, such as respiratory distress syndrome or smoking, can cause the alveoli to collapse and increase the resistance. Here's a quick recap of the pressures. The pressure around the environment surrounding the body is called atmospheric pressure. The pressure in the space between the visceral and the parietal pleura is called the intrapleural pressure in a small little membrane. And the pressure inside the alveoli is called intrapulmonary pressure. And then the transpulmonary pressure is the difference between the intrapulmonary pressure and the intrapleural pressure, and this represents the amount of force that tends to collapse the lungs. So the process of ventilation from resting breathing. Quiet inspiration is initiated whenever the brain's nuclei in the respiratory centers send signals to the muscles of the diaphragm and the external intercostals to contract. This will then increase the cavity volume, decrease the pressure, so the air goes into the lungs. During expiration, there's a stopping of the signals so that the diaphragm and external intercostals can relax. The lungs begin to recoil, and then the volume decreases, pressure increases, and the air goes from the alveoli out to the outside world. So just prior to inspiration, the atmospheric pressure is equal to the intrapulmonary pressure. Lungs begin to expand and the intrapulmonary pressure decreases. Air moves from the atmosphere to the lungs. Pressure then maintains an equilibrium. During expiration, the thoracic volume declines and the intrapulmonary pressure gets greater than the atmospheric pressure, and then air moves out and then resets again. And you can see right here the graph showing you inhalation, exhalation. It's a small minor changes in 1 to 2 millimeters of mercury of pressure. There are several non-breathing air movements: coughing, sneezing. These are to help clear irritants from the airway. Yawning, resulting from deepest possible breath. When you get tired, hiccuping, a spasm of the diaphragm that causes a rapid burst of air flowing through the vocal cords. And of course, laughing, crying, which are emotional states that drive ventilatory pattern. And we also have a clinical application called the Valsalva maneuver, which is an attempt to exhale if the airway gets closed. It's going to help somebody regain the ability to breathe. Ventilatory volumes and capacities. Minute ventilation refers to the amount of air that is moved between the atmosphere and the alveoli in 1 minute. In a normal adult, we breathe about 500 mLs per breath, or basically 6 liters per minute. The alveolar ventilation is the amount of air that reaches the alveoli and is available for gas exchange per minute. This, in a normal adult, is about 4.2 liters per minute. In order to measure the respiratory function, a device called a spirometer can measure the volumes that enter in and leaves the lungs. We'll start with the first value, TV, tidal volume. Tidal volume is the amount of air inhaled or exhaled during the breath during quiet breathing. IRV, inspiratory reserve volume, is the amount of air that can be forcefully inhaled beyond tidal volume, and this is a measurement of compliance. Expiratory reserve volume, ERV, is the amount of air that can be forcefully exhaled beyond the tidal volume, which is a measure of the lungs' elasticity. Residual volume, or also known as RV, is the amount of air left in the lungs even after the most forceful expiration possible. We can take these volumes and combine them together to create capacities. IC, inspiratory capacity, is the sum of the tidal volume plus the inspiratory reserve volume. FRC, functional residual capacity, is the sum of the expiratory reserve volume plus the residual volume. And then the vital capacity, VC, is the sum of the tidal volume plus the IRV and the ERV. And then when we sum all of them together, the vital capacity plus the residual volume, we then get the total lung capacity, or TLC. With the help of these capacities, we can then measure the flow rate by which how the lungs are performing. The first type of flow rate we'll talk about is FEV, forced expiratory volume. This is the percentage of the vital capacity that can be expelled in a specific period of time. FVC is the forced amount of vital capacity, and the PEF is the peak expiratory flow rate at a specific time. These rates can provide information about whether or not the lungs are closed, collapsed, or have any kind of resistance because of mucus or buildup. Over here on the left is a graph showing you different heights of men and women. The x-axis shows you age. So as you get older, the capacity does go down, and the flow rate goes down because of a reduce of elasticity and compliance. Ideally, this range is where you have the maximal amount of movement of air in liters per minute. So this is the optimized region, and ideally you want to seek into the optimal range. And these pulmonary function tests that measure PEF, FEV, FEC provides a means of distinguishing between various types of chronic obstructive pulmonary disorders, or also known as COPDs.